Good afternoon, everyone. Thanks for joining us. We're going to give it a couple of minutes to fill the room here. Good afternoon again, everyone. We'll give it about another minute to fill the room. Good afternoon, everyone, and thank you once again for joining us for our weekly Wednesday webinar series. My name is Brett Spitali. I'm the Vice President of Advancement here at NHF. On today's webinar, we will discuss recombinant factor VIII fusion protein for first-time immune tolerance. Please feel free to ask any questions by using the Q&A feature at the bottom of your screen. We have an NHF staff member monitoring these questions, which we will present to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, May 12th. Today, I'm joined by Dr. Lynn Malec, Senior Medical Director of VIII Medical Science Institute, Medical Director of VIII Comprehensive Center for Bleeding Disorders, Associate Investigator of VIII Blood Research Institute, and the Associate Professor of Medicine and Pediatrics at the Medical College of Wisconsin. Thanks so much for joining us today, Dr. Malec, and I will now turn it over to you to get us started.
Okay, great. Well, thanks for the invitation to speak today. And as mentioned, we're going to be talking about a newly released article that features a study on the use of recombinant factor VIII Fc fusion protein for first-time immune tolerance. So here are my disclosures. And to start with just a little bit of background in the next two slides, for those of you that may be less familiar with the concept of inhibitors in hemophilia, about a third of patients with severe hemophilia A will develop an immune reaction to their factor VIII medication. And these immune reactions, which we term inhibitors, then make that factor VIII preventative treatment if a patient was receiving prophylaxis, or if they were receiving factor VIII for breakthrough bleed treatment, those inhibitors make that medication ineffective. So options historically to prevent bleeds with patients with inhibitors were really few before we had the advent of non-factor therapy, which was approved in 2017. Our current licensed non-factor therapy being emicizumab. And then in terms of options to treat bleeding events, this really has historically included our bypassing agents. And in several different studies, what we know is that these bypassing agents, although they do help with stopping bleeds, they don't provide the same sort of efficacy or effectiveness as factor VIII medications would. And so for this reason, there's been a longstanding historic focus on what we would consider inhibitor eradication. So trying to get rid of that immune response to factor VIII using a process called ITI. And really for decades, we've used various treatment protocols. At the end of the talk, I'll highlight what some of those historic protocols have been, again, to try to get rid of inhibitors. In the hemophilia space, we call this immune tolerance induction, or the shorthand being ITI. The way that I like to explain it to my patients or my trainees that might be with me in clinic is very high level. This is conceptually like allergy shots. So really giving high doses of exposure or treatment to try to get that immune response to be suppressed. Historically, we've used high doses of factor VIII compared to what you would receive otherwise for routine prophylaxis. And within the range of kind of high dose, there's a pretty wide spectrum. And again, I'll highlight some of these different kind of named protocols at the end of the talk that may vary from 200 units per kilo daily, again, all of this given IV, or somewhere between 50 and 100 units per kilo 3 times a week. So again, a much more escalated treatment pattern than we would see otherwise in patients that have hemophilia A. The aspect of ITI success rate historically is thought to be about 2/3 of patients, so a range that kind of spans 60 to 80% of patients, somewhat depending on the study. But that being said, we know that this is very time intensive for patients and families to do this high intensity IV treatment. And of course, when we're using hemophilia therapies in this intensive way, is also very costly. And with this in mind, there has been ideally a focus on improving inhibitor treatments and that goal of inhibitor eradication. And this is one of my personal areas of both clinical interest as well as clinical research interest. I think some of this stems from my time in training in Pittsburgh when I cared for a couple of really difficult to treat inhibitor patients where they unfortunately were, routinely in and out of the hospital. So really with the identification of a need to have better treatment options. So along the way, there's been studies on different doses of medications, and I highlighted that some in the last slide. So that idea of, are you using 200 per kilo, or are you using 50 per kilo? There's been studies on different types of medications, typically by the class of medication. So the idea of plasma-derived factor VIII concentrates versus recombinant concentrates. But as we have had newer products come to market to be able to be prescribed in hemophilia, it really has raised the question of, what about the newer generation of products, including the extended half-life products? And I'll talk about how the study that we're highlighting, the publication that we're highlighting today that I authored, really builds on observational studies. And the main study that I would like to highlight is this study here, which was called Anti-Hemophilic Factor Fc Fusion Protein and ITI, that was published by Dr. Manny Carcao in 2018. And this was an observational study, so meaning that patients weren't enrolled and receiving the same sort of treatments depending or kind of no matter what center they were treated at. So these would be patients that were from really a variety of centers. And the study was also done what we call retrospectively. So meaning that patients, we looked back at how they had done historically with different treatments. And when Dr. Carcao really gathered the information from different centers, he raised some of the question of if there would be what we would consider immunomodulatory, so some aspect of changing the immune system that may be related to the FC portion of the FC fusion product. The FC aspect is actually a fragment of an antibody, so an immune cell made by the immune system. And what they had seen by some of this initial retrospective study was that 7 of the 12 patients who had received something called rescue ITI, meaning they had received a prior course of ITI and were undergoing a second course, they achieved a negative inhibitor titer, so meaning that inhibitor went away. There was 4 of 12 patients in that rescue ITI arm that had complete tolerance, and we'll talk a little bit about what that often means in relation to the study that I'll highlight. And then in total, there was 8 of 19 patients that were reported that were a combination of patients that had first-time ITI, so new ITI, and that rescue ITI that had success to some degree with using this product. The other interesting thing was that there was somewhat of what we would consider a signal, so meaning nothing that was proven, but one thing that was seen is that there was potentially a faster time to both those kind of partial and complete tolerance aspects for patients. And what they saw was that the median time to having a negative inhibitor, meaning the inhibitor wasn't able to be detected in the blood, was around 14 weeks. So with that in mind, that's really what I would consider some of the, important nuts and bolts background, to then talk about the study that we're going to highlight today. And this is known as the VIII study. This was a clinical trial that was just recently published in Blood at the end of April. This was a study that was single armed, meaning that all patients got the same sort of treatment. Open label, meaning that everyone was aware of what the study medication was, and it was a multi-center study. It was actually a global study, so there were sites here in the US as well as around the globe that contributed patients to the study. So now diving in a little more in terms of the aspects of the study. So in terms of who is eligible for this study, the key inclusion criteria, so the things that a patient kind of must have before they would be able to be a candidate for the study. This included males of any age with severe hemophilia A. They would have a history of a high titer inhibitor, and this is in line with what we would consider the same historical designation of 5 or greater Bethesda units. They would have had prior treatment with any plasma-derived or recombinant conventional or extended half-life factor VIII. So really could have been treated in a variety, a variety of ways historically. The key exclusion criteria included if you had another bleeding disorder besides hemophilia A, if you had had previous ITI, so again, the concept of rescue ITI for this study, you would not have been eligible. And importantly, I think a distinction here is that you could not be on emicizumab or any other immunomodulatory therapy, so that bleed control with emicizumab, which I will highlight kind of after discussing this study, patients in the VIII study were not on EMI, and they weren't receiving any sort of attempts to alter their immune system. Then focusing on the study design of VIII, this is really broken down into these different aspects of the study. First, patients underwent screening to make sure that they were actually eligible for this, the study, and then had a baseline visit. Then they began the ITI period, which lasted up to 48 weeks. Here, patients received the recombinant factor VIII Fc fusion protein dosed at the high dose of 200 units per kilo per day until the time of tolerization. It was allowed that patients would receive bypassing agents for acute bleed control, but nobody was on this as part of a planned prophylaxis, meaning that they weren't receiving bypassing agents every day or at any kind of predicted interval, along with the use of the Fc fusion protein. In patients that then received the criteria of, or met the criteria for having reached tolerance, they would have undergone a tapering period that lasted up to 16 weeks, with the goal that they would taper down to a prophylactic dose of treatment. And then there was a follow-up period that lasted up to 32 weeks. And this was, again, the plan that these patients would continue prophylaxis with dose adjustment based on their treating physician. And then they'd reach the end of study and ultimately have a safety follow-up period. When looking at what the endpoints were of the VIII study, the primary endpoint, so the main goal of the study, was the time to ITI success, or what we call tolerization, within that maximum of 48 weeks of ITI using the factor VIII Fc fusion protein. When we looked at, well, how is ITI success defined? This was defined really using the measures of success that have been defined and utilized for other studies and are consistent with what we would consider national guidelines. And this includes the aspect of patients now going from having had a prior positive or Bethesda titer that was above the limit of detection. That they would have a negative Bethesda titer on at least 2 consecutive visits. They would have a normal recovery, so looking at how high their factor VIII would go after receiving a dose on at least 2 consecutive visits. And the normal recovery cutoff was at 66% of expected. And then also having normal pharmacokinetics, really based on the half-life of the medication, meaning that the half-life, if you went from 100% down to 50% correction, that was at least 7 hours or longer. There was a variety of different secondary endpoints, and some of these we will highlight, but these included that subjects were achieving ITI success, the look at the amount of factor VIII FC consumption or drug utilization, annualized bleed rates, as well as adverse events, and I'll highlight these as we go through the study results. Now turning to the subjects that were enrolled in this study. So there was a total of 16 subjects that were enrolled. And I think for many of you on the webinar will recognize that although about a third of patients with hemophilia, severe hemophilia, go on to develop inhibitors, that it's historically quite challenging to do clinical trials in this patient population, because at any one center, there may be 1 or 2 or potentially more, but not really lots of patients at any one center at a given time that are potentially eligible for the study. And then here in this table, it really outlines what the aspects of the baseline demographics and characteristics of patients are. You can see the median age at the time of informed consent or enrollment into the study was just a little over 2 years. This is in line with what we know about typically young children being the ones to develop inhibitors. It was predominantly a population that was majority white. And then we can look at the various characteristics, including the median time from inhibitor start or from inhibitor detection to the start of ITI, what some of the history of the peak titers were, inhibitors right before we started, and then some of the aspects of the clinical history, family history, and genetics of the subjects that were enrolled. When we then look at some of the aspects of the primary endpoints, we did see rapid tolerization that was achieved in the majority of these first-time ITI subjects using the recombinant factor VIII FC fusion protein. So again, back to those 16 patients, they had received at least 1 dose of the drug. ITI was deemed to be successful, so meeting those 3 parameters I outlined in 10 patients, which is 63% of the cohort. There was 1 patient who met criteria for partial success, and then 5 individuals who failed in the ITI attempt. And here it has outlined in the table below some of, I think, for me, the important aspects of also the study is kind of when this happened. So typically we would see those criteria, a negative inhibitor, an incremental recovery of at least 66% and a half-life of greater than 7 hours kind of happen sequentially. And you can see the number of patients that met those milestones and then the time in weeks, the median time in weeks outlined here, as well as what we consider the interquartile range. So really the median time to patients meeting those metrics for those that did have success was 11.7 weeks. So with this in mind, again, that looking at that primary outcome, we found that there was a rapid tolerization that was achieved in the majority of first-time ITI subjects, and that is really displayed here graphically with this Kaplan-Meier curve. And the Kaplan-Meier estimate was that ITI success rate was overall 67%. Now looking towards some of the secondary objectives, as I mentioned, the primary objective really focusing on who met criteria for tolerization. Here we see some of the aspects of the secondary outcomes, this one being the consumption of factor VIII on study, as well as the use of bypassing agents during the ITI period. And you can see in this first row, we have the aspects of the factor VIII consumption, patients that received either APCCs or recombinant 7A, and then what on average, or the medians, excuse me, were their annualized consumptions based on product. And then this is segregated into kind of the total aspects and by those different study time points, the ITI period, the tapering period, and the follow-up period. Now, when we turn to bleeding rates, again, this study utilized what we would consider kind of a historic measure of bleeding termed ABRs, or annualized bleeding rates. So when we look at the ABRs during each period of the study, again, bucketed by those that were receiving ITI, those that had a tapering or the follow-up period, you can see the number of subjects at each time point. And you can see that overall, both the median and the mean bleed rates, especially once patients achieved tolerization. So these would be patients that entered tapering only because they met those criteria for ITI success. In these patients, the bleed control was quite good. So an overall median ABR of 0 and mean ABR of 1.1. Then when we look at some of the aspects of how well this regimen, both in terms of the product itself, as well as the kind of the treatment regimen, how this was tolerated, we overall found that this was a well-tolerated approach for first-time ITI. Here we have listed first what we would consider the treatment emergent adverse events. And you can see that, again, these were young children. This would be all reported events as part of the clinical trial. You can see the overall number of subjects who had at least one treatment emergent adverse event was really the whole population. And then we look at the aspects of the treatment emergent serious adverse events, or SAEs. We can see that occurred in 9 or 53% of the population. That said, we had no patients that discontinued treatment and or the study due to an adverse event. So again, nobody coming off of that protocol, and there were no deaths. And then when we look at the aspects of the treatment emergent serious adverse events, in total 9 subjects again reported these, all of it which were thought to be unrelated to treatment. And those specific TESAEs that occurred in more than 2 subjects are listed below. These included a vascular device infection, a contusion, and hemarthroses, and you can see what those numbers were across the cohort, and they occurred in a relative minority of patients. I'm sitting too still here in my office. Turn the lights back on, sorry. So overall, also importantly, when we would think about, what happens when we're using this high dose of an extended half-life product, there were no thrombotic events that were observed in any patient during the study. So really, in summary and conclusion, again, of this publication, the key takeaways are that the recombinant factor VIII FC fusion is the first extended half-life factor VIII therapy that had prospective data for first-time ITI in patients with severe hemophilia A that had high titer inhibitors. When we look at those patients, we would see that this was overall well tolerated and offered a rapid time to tolerization. So how many weeks that it occurred, again, the median was 11.7 weeks with ITI success, and there was no relapse in almost 2/3 of patients. And a conclusion, importantly for the study, is really thinking about optimizing ITI to eradicate inhibitors remaining priority. So now for the kind of last half of the talk, having gone through, again, the essential data from that recent publication, I wanted to shift my focus a little bit to think about some of the aspects of inhibitor eradication in the era of emicizumab. And this has been something that I think has been a talked about concept, certainly in our region here in Wisconsin, as well as with colleagues that I have across the country and really across the globe. So I think first, fundamentally, why think about ITI? So why think about inhibitor eradication in the era of emicizumab? I think I bucket these into some of the aspects of safe treatment for breakthrough bleeds, thinking about managing patients optimally with surgery, including major surgery, and then thinking also, I put here access to gene therapy, but certainly, potential other therapies that are coming down the pipeline. I think some of the aspects of the safe treatment of breakthrough bleeds comes from the idea that in the early pivotal trials of emicizumab, we know that patients still experience bleeding events. So just like any other hemophilia product, there wasn't kind of perfect protection against bleeds. And we saw that patients who were managed with recombinant VIII and emicizumab, this seemed to be safe. But we know that not all patients respond to that, and that in some of the early Haven studies, again, the pivotal trials for emicizumab, we saw that the use of prothrombin complex concentrates at standard doses was potentially associated with increased risk of thrombosis as well as thrombotic microangiopathy. I think increasingly we do have some published data related to surgery, but all things considered, there is reasonably limited experience of how to manage patients with major surgery when they're receiving emicizumab. And then finally, some of the aspects of access to gene therapy. So if we have patients that continue to have persistent inhibitors, what would that mean for therapies that may come down the pipeline? The AAV-based gene therapy trials that are in latest phase development, and I'll highlight this at the end of the talk, really are restricted to patients without inhibitors, with some of the newer studies including those patients, but some of the first to market products, we certainly know what we would anticipate that they would exclude patients with either a current inhibitor or a history of a prior inhibitor. So in thinking then about that as kind of why is it important to eradicate inhibitors, some of the data really, again, supports that inhibitors are associated with an increased risk of bleeding, increased risk of joint damage, decreased quality of life, higher healthcare costs, and increased risks of mortality or death as compared to a patient that does not have an inhibitor. And in terms of kind of how we're able to manage patients, we know that immune tolerance induction is really the only clinical proven strategy for inhibitor eradication, and therefore is the recommended treatment option for inhibitor patients. We do have long-term, more than 40 years of clinical and real-world experience, and as I mentioned, a reasonable success rate for patients. So now turning a little bit of a focus into what other strategies are being looked at or investigated. Here I highlight what are some of the historic kind of protocols, the Bonn protocol, the Malmo protocol, the Dutch protocol, really all various different protocols looking at the eradication of inhibitors. Also wanted to mention one that many of you may have heard of, which is the Atlanta protocol. And this is where you have ITI, so factor VIII exposure with the intent of getting rid of an inhibitor that is combined with prophylactic emicizumab. So patients are on prophy with Emi at regular dosing regimen. As a reminder, back to the VIII study, patients did not receive emicizumab during that study for bleed control because they would have been excluded. And this is a slide that I've taken from a presentation from Dr. Sidonio, really highlighting the Atlanta protocol. And some of the really initial data and kind of thoughtfulness about this has come out of his group in Atlanta. When emicizumab is used in inhibitor patients undergoing ITI, this treatment regimen, which is listed here, is the same regimen that we're utilizing for patients who aren't undergoing ITI. It aligns with the way the drug is meant to be prescribed. And then his group has been utilizing a dose of factor VIII that's 100 units per kilo IV 3 times a week. And they were starting this after emicizumab was initiated. So looking a little bit in terms of what the Atlanta group, including Glebi Batsuli, Robert Sidonio, and Shannon Meeks have published. They published some of their early work. This was initially published at or presented at one of our American Society of Hematology meetings. They really published some of the first data. Here, 7 patients that had been receiving this Atlanta protocol for a median of 35 weeks. And what they saw was that they had patients that did achieve a negative inhibitor titer, so 3 of their 7. 2 patients had achieved a normal factor VIII recovery, and there were 9 bleeding episodes in 4 patients. But importantly, at the time, there was real potential concern about, is this a safe thing to do in the space of inhibitor ratification? And they were one of the first groups to report, again, the use of emicizumab while patients were undergoing ITI, and they had not seen any thrombotic complications in their patients. Wanted to then highlight another publication, I think for both patients and providers. This is I think a really thoughtful publication that really talks about how could we standardly approach ITI. And I think this is, certainly something that I'm very passionate about, knowing that in a given year, I may have 1 or 2 patients with an inhibitor that may be the same at another center. And how do we make sure we're doing what's best for our patients using the best data? And so thinking about having really standardized approaches that we would have, across the nation, so that if you were being treated here by me in Wisconsin, it would be the same as if you were being treated by a physician, let's say in California. So with this recommendation, this was published by a group that was called themselves the VIII group. They published this nice kind of treatment algorithm, walking you through it. Here they would have a patient with hemophilia A who develops an inhibitor. Some of the goal would be to start immune tolerance induction as soon as the inhibitor is detected, which is different than some of what we've done historically, where we would wait for the inhibitor titer to fall. There's certainly data now that supports we would do more early initiation of prophylaxis. They have some degree of risk stratification based on what your Bethesda titer is. So putting you in either a good, poor, very poor, or very good category. They then have suggestions of the dosing that you would have, either what we would consider a low dose, 15 units per kilo, or 100 units 3 times a week, up to 100 units per kilo daily, or more of that high intensity 200 units per kilo per day. Then do some escalation if inhibitor titers rise. Rethinking kind of where things are at a 9-month time point, really depending on what the inhibitor titer has done. And then thinking about kind of that final outcome. How do we define a patient? Then they also proposed a novel kind of treatment regimen that really involved the use of emicizumab. So starting point here would really be the same, that you have a patient with hemophilia A who develops an inhibitor. Then they would go on a regimen, of 50 units per kilo 3 times a week with emicizumab. If emicizumab is not desired by the patient or the family, you would revert to the algorithm that I showed in the prior slide. And then you'd think about escalation if the inhibitor titer is actually on the rise to more of that 200 units per kilo daily. There would be, again, a decision point where we would relook at how things are responding here at a 6-month time point, and then very similar ITI kind of final outcome assessments, with the total duration of outcome really being thought to be assessed likely at 18 months or 33 months, 18 months being kind of a newer thought of the duration of therapy. So then thinking about kind of how are we capturing some of this data, both here in the US as well as across the globe, wanted to highlight one study, which is called the MOTIVATE study, which stands for the Modern Treatment of Inhibitor Positive Patients with Hemophilia A. This is another study that's led here in the US by Dr. Sidonio. And this is an investigator-initiated international multi-center prospective, meaning we're following patients forward in time with ITI. Patients can be of any age with inhibitors, with or without prior unsuccessful ITI. So again, those first time as well as rescue ITI patients. The treatment itself is at the discretion of an investigator or a clinician, meaning the physician at the center, according to what is thought to be their routine clinical practice. And the plan is that patients will be followed for a maximum of 5 years. The objectives of the study, including capturing different approaches to the treatment and management of people with hemophilia A and inhibitors, to document really what are our current ITI approaches, and then to gather more data and to look at the efficacy and safety of ITI, including with emicizumab prophylaxis, as well emicizumab prophylaxis alone, as well as emicizumab used along with ITI. Very high level, the groups are going to be really bucketed in terms of whether or not patients are going to be receiving ITI or not. The way that Dr. Sidonio received his funding, there is specificity around what type of factor VIII product patients receive. And then the aspects of defining success are very similar to what we've done historically and align with the publication that I highlighted by way of VIII. And then finally, before we kind of wrap up and summarize, I did want to mention, some of the aspects in gene therapy in hemophilia A in patients that have inhibitors. And we, as I mentioned early in the slide, the current AAV-based gene therapy that's really in late stage of development or undergoing current FDA review to date has excluded patients with current or prior history of inhibitors. So we would assume that if the products are approved, they would fall in line with the patient's eligibility criteria from the clinical trials, so likely exclude those patients. That being said, I don't think that is a reason to not have hope, because certainly clinical trials will continue to evolve, and there certainly is, an important need to focus on optimal therapies of patients that had prior inhibitors. I did want to mention a study that we have here in Wisconsin at the Medical College of Wisconsin, where we're actively recruiting adults with hemophilia A and a history of inhibitors. This can be a current inhibitor or a prior inhibitor, even potentially remotely when someone was quite young. And this was a presentation on this clinical trial that actually I had the opportunity to present as a Wednesday webinar previously, along with Dr. Mary Eapen, who's pictured here. She is the transplant physician that really leads the care of patients with hemophilia during this clinical trial. And then here is Dr. David Wilcox. He is the PhD scientist that's part of the study. And then I serve as the person that's providing the hemophilia care. So provided here is really a link to that prior webinar, as well as the aspect of where you could potentially find more information about this clinical trial. We have dosed our first patient who's now surpassed the year mark from being dosed on the study. And if you have more questions, I listed Dr. Epen's email there, as she is one of the people that you could reach out to for more information. So in summary, before we turn really the last 20 minutes over to the question and answer session, I think, again, I'm happy to have been here to present the data from the VIII study. This was a study that, took a long time to see to completion, but ultimately I think has provided important data for the community. I think, we all recognize that there's ongoing innovation in hemophilia and in the bleeding disorder space. And I think it's important that as new products come, we think about their use. And certainly VIII study demonstrates the safe, effective, and rapid tolerization using recombinant factor VIII Fc fusion protein. And I think with that, I'll stop with saying, I think, myself, as well as, many others in the community, really have a commitment to understanding the impact of new therapies that come to market, with really a focus on improving the life of all patients with inheritable blood disorders. And with that, we can end and turn things over for questions.
Great. Thanks so much, Dr. Malec. We do have several questions that have come in. I'm going to start right from the beginning here. The first one is, why were women not included in the study?
It's a very good question. So I think I don't have a great answer for why they wouldn't have been included. And quite truthfully, probably more of these would have been young girls, if you remember what that median age was. I think more and more, in my mind, there's nothing that biologically different about a woman or a girl that would have an inhibitor. Again, these were all individuals that had severe hemophilia. So this would be a woman that would have received, 2 hemophilia gene copies. But again, I don't think there's a great explanation for that. And I think more and more as a community, we recognize that that has been, an often excluded group, and we need to really just do better for the future.
Thank you, Dr. Malec. Next question that comes in, what definition of tolerance was used? Was it recovery? Was it half-life?
So it was really all of those. So you would have had to have kind of that full category of having an undetectable inhibitor titer. So for most laboratories, that's less than 0.6 Bethesda units. That's the same at our institution here at the VIII Diagnostic Labs. That's the same that was used in the centralized lab. Having a recovery or factor VIII rise of at least 66% of expected, and having a half-life of at least 7 hours or more. So it's really those kind of 3 markers in triplicate you would have had to be considered, a full success.
Great. Thank you. Next question is, what Bethesda assay was used? Was it a modified assay?
Yes, it was. And that was done, all of the ultimate treatment decisions were done through central lab verification, and that is how the assay was done.
Great. Next question is, 67% is strikingly similar to international ITI study and registry data. What's the advantage of using factor VIII Fc in this protocol?
Great question. I think for me, it's really the time metric. So I think, historically, international ITI study went out to 33 months before they would consider someone a success or a failure. Here in this study, it went up to 48 weeks. So I think, for me, my team here knows I'm very passionate about the actual interface and interaction with patients. I think that's the piece that fills my cup up is being able to, interface with patients and really be their doctor. I think that aspect of, we're going to try ITI and we're going to decide almost 3 years from now whether that's a success or not, versus maybe the potential of thinking about, okay, well, why don't we try this for a year and see how things go? I think that is impactful for both patients and providers. So I think the overall success rates are totally right. Whoever answered that or asked that question, I think you're totally right. Those are very similar to international ITI success rates, but I think some of the key aspect is, you didn't necessarily have to go out that full duration to see patients achieve tolerance.
Great. Thank you. Next question. Love this question. It seems like ITI is recommended according to your talk. My insurance company denied paying for factor VIII ITI, saying that my son's inhibitor was being treated with Hemlibra. What can I do to get the doctor to do?
Yeah, I mean, I think, after this publication came out, I got, several colleagues that either emailed me or text me or sent me a message on Twitter. I think this is really some of the data that we need in the modern era to talk to insurance companies. So I recognize, sometimes the difficult decision making that they have as well. They don't want to do something that is futile, but I think any clinician in the hemophilia space could write a strongly supported by science letter that emicizumab does not do anything for inhibitor eradication. So again, it's not ITI, it's not factor VIII exposure. And so it may be kind of a two-parter, explaining what immune tolerance induction is, also providing some of the data from, studies like this, where you could think, again, we're not committing to maybe years long ITI, but a trial of a specific duration. So, I think most, if the person that asked that question is in a hemophilia treatment center, that's where I'd say go back to your team and say, this is something that I want for my child. How do I interface with the insurance company to make that happen? I would say, these are letters that I write or have my team help me write, week in and week out. And I think that's, part of our job as physicians is to do the advocacy piece.
Yeah, great. Thank you, Dr. Malec. Along those same lines, with all these studies that are now available, how do I know which one is best for my son?
Oh, yeah, good. Another great question. And I think, as a mom, I don't have kids with hemophilia, but at the same time, I feel the weightiness of really, always wanting to do what's right for your child. So I don't know that there's a perfectly right answer to that, but I think, when my patients come to clinic, I like to talk about, therapies in buckets. So what is your current medicine you're on and how is that working? Bucket 2 is, what other medicines could I prescribe for you today? And how do I think those medicines may or may not work best for you or your child? And then bucket 3 is more the idea of, what's in a clinical trial space and what I think is, coming down the pipeline based on what I've heard at scientific meetings or webinars or those sorts of things. And I think in a really great way in the hemophilia community, we now have the option to not have one size fits all treatment. And so if I see, 6 patients in a given half day of clinic, what's right for them may be totally different. And my job is to, provide the educational foundation of what the options are. But ultimately, if all 6 people choose a different treatment option, that's actually great, because I think, people have different activity levels, people have different veins and different ability to access their veins or, have a central line, all those sorts of things. And so I would say a lot of this is, you're attending this webinar, continuing to have, your own kind of desire for further education, and then really making sure that, you come equipped to ask those questions of your care team. Because I think, certainly any care team, that's what they want to do and should want to do is to tailor, your child's specific situations to what the treatment options are.
Great. Next question that comes in. Since the outcome with this protocol is very similar to all prior ITI data, have we reached a quote unquote biological wall against which we cannot go beyond 70% tolerance success?
Yeah, another great question. So I think the thing for me, as someone who's also still, very engaged as a clinical and ultimately translational researcher, is I don't think we've fully unlocked all of the questions of why. So kind of why inhibitor development fully happens in the first place. So what are those initial kind of immunologic signals that happen? Because we have to remember, by slide 2 of, if we have a third of patients with severe hemophilia A developing inhibitors, well, that means 2/3 do not. And they are patients who also don't make, a functional factor VIII on their own. And so kind of why do their bodies receive supplemental factor VIII and not make an inhibitor versus those that do make an inhibitor? And so I think where the future, in my mind, will lead us is if we understand some of that basic biology better. I think that could unlock the aspect of more tailored therapy, because it may be that some patients do need some sort of immune modification, but not all. And maybe some patients need tailored therapy, but not all. And so I would say without better understanding some of the whys of this happening, maybe we've kind of hit that wall, but I don't think that's a wall that's, impenetrable for the future. I think we just need better understanding of the mechanisms.
Great. The next question that comes in, what is the cost of this protocol versus other protocols?
That's another good question. So I don't know that offhand. We didn't do a separate kind of cost utility or cost effectiveness analysis. I have some training in that previously in Pittsburgh. I think those would be, great questions to ask. Of course, as a class, the extended half-life products, per unit are more costly than the standard half-life products. So I think there is a cost factor just associated with the, the increased cost of a specific therapy. But the, dollar per dollar analysis, just hasn't been done.
Gotcha. Next question is, how will they continue this progress with research with inhibitor patients? Will this help people with inhibitors become eligible for new treatments such as gene therapy?
Yeah, great question. And I think this is where, especially in the gene therapy space and given the person, and I'm the person that's, helping lead the charge at our own institution, along with our pharmacists to really, fully develop our gene therapy program here to be able to deliver commercially available gene therapy, as well as having participated in the clinical trials. I think, some of this will, in my mind, now this is, I will say, opinion, is, if you have a patient that has had a tolerized inhibitor as a toddler, and now they've gone from, 2 to 22 or 32 or 42 or however old, and they've decided that gene therapy is right for them, I still think the likelihood of gene therapy in that setting, now causing an inhibitor to come back is very different than in a patient that was recently tolerized or certainly who has a persistent inhibitor. So my hope is that the gene therapy studies that have been done and are in that late phase, so ideally going to the FDA for review, they've excluded inhibitor patients because they kind of had to start somewhere, but not that they would exclude inhibitor patients forevermore. And I think the study that I mentioned that I'm a co-investigator here, that is a study where it's a different technology. It's a lentiviral based gene therapy. Patients that have active inhibitors are eligible for that study. So some of it is going to be, a tailoring of the technology. Some of it's also going to just need to be, some of our pharmaceutical partners really doing the studies in patients that have previously tolerized inhibitors.
Great. And I've got one more question for you, Dr. Malec. It's really exciting to hear about the platelet gene study. Where may I find more information about this?
Yeah, so this will be, I think Friday, Brett, you said the publication or the presentation rather will be linked. If you want to grab down your pen, again, kind of the study team, Dr. Wilcox is the basic scientist who had really had the heavy hand in the development of the technology. Dr. Epen is the transplant physician. So they're, the leaders of the program, if you will. And then I'm a co-investigator, and I really do, all of the review of a patient's hemophilia history, as well as their management specific to the study. So those 3 links there, one is our prior webinar. The second is the location that any clinical trial needs to be registered at clinicaltrials.gov that has specificity of that study. And then I listed Dr. Epen's email on the clinicaltrials.gov website. You can also get her email as well as the email for Ariel, who's our lead coordinator for the study.
Great. Thank you so much, Dr. Malec. Really appreciate that. I'd be remiss to say Dr. Valentino is with us, but he's unable to come off mute. He wanted me to personally thank you for being here and delivering this today. So thank you for that. And I'd like to thank you as well, too, for taking the time to come join us this afternoon. Please note that this recorded webinar will be available on May 12th. At hemophilia.org under the events tab with all of our other archive webinars. Again, Dr. Malec, thanks for your time. Thanks for presenting for us. I know you had to switch some things around in your personal schedule. I truly appreciate that.
Of course.
Have a wonderful rest of your week and thank you for joining us, everyone.
Yeah. All right. Take care, everybody.